My name is Alejandro. I'm an endocrinologist here in Miami, Florida. I want to take the opportunity first and foremost to thank you for allowing me to share some thoughts, to review the guidelines, and go over some new information regarding the prevention, the diagnosis, and the treatment of osteoporosis. When we talk about osteoporosis, we usually think it's a disease of elderly women, but now we know that it can involve men and women of various ages. And the question has always been, who do we screen for osteoporosis? And obviously, we're going to screen all women over the age of 65, but we should also screen those people who have fractures, right? Those people who have a family history of osteoporosis, those people who have early menopause, women with either early menopause or surgical menopause. These are people that are at risk. And we're going to talk a little bit about the risk factors associated with osteoporosis, and then it's all going to make sense. So we're going to start off first defining what is osteoporosis, how do we make the diagnosis of osteoporosis, who do we treat, why do we treat them, and then we're going to finish up looking at how we treat them in terms of medications. When you go back to the diagnostic criteria for osteoporosis, it has not really changed much. I mean, if you look at this slide, it's from 1994, published by the World Health Organization, and the diagnosis is clear, right? You get a T-score. If it's less than negative 2.5, you have osteoporosis. If it's between -1 and negative 2.5, you have osteopenia, and normal bone density is considered anything above -1. Okay. Remember, and I always tell the patients, when we obtain a bone density, what we're doing is that we're comparing your bones with the bones of healthy, young women between the age of 20 and 29. Okay. And what I tell them is if your bones are exactly the same as a 20-year-old woman, you get a 0. And a 0 is like getting 100 on the test, right? But because of age and maybe other risk factors, getting 100 is going to be hard. And then we calculate how many times weaker your bones are compared to a young woman. Okay. And that's how I explain it to the patient. These are negative numbers. That 0 is the goal. Less than -2 is considered osteoporosis. So as I mentioned on the earlier slide, it's simple, right? Less than 2.5, you have osteoporosis. But what about those patients that have osteopenia, right? Between -1 and -2.5. What do you do with them, right? Well, if they've had a fracture, if they've fallen and they have a fractured hip or a fractured vertebrae or a fracture of the distal forearm, then you treat those patients. Why? Because by definition, by having a fragility fracture, regardless of your bone density, you have osteoporosis. And then we're going to talk about the newest screening modality, which is to include a FRAX score to these patients, those patients with osteopenia, and then use the FRAX score to determine whether that patient should be treated or not, despite only having osteopenia on the bone density. So we're going to talk about that as well. These are possible secondary causes of osteoporosis. This is important, right? If you have a patient with primary hyperparathyroidism, one of the consequences of that would be the development of osteoporosis. Patients with hyperthyroidism can develop osteoporosis. Patients with celiac disease, right? They don't absorb vitamin D, they don't absorb calcium, they can develop osteoporosis. Don't forget Paget's disease, right? That could do it. Multiple myeloma, those patients can also develop osteoporosis. So these are possible secondary causes. These are a little more rare, right? Acromegaly, Cushing's disease, hemochromatosis. But on this slide, I think the most important one is to remember hypogonadism, especially in men, okay? When you see a man with osteoporosis, you have to think hypogonadism, low testosterone levels, okay? There isn't much data whether replacing the testosterone will prevent fractures, but what I've seen from my experience is that you want to attack it both ways, right? You want to replace the testosterone and at the same time treat them for their osteoporosis. So who should have a workup, right? If you get a patient who's less than 65, you're going to have to screen for all these things, right? If you have a patient less than 50, right? Young person, then that's clearly abnormal. There's probably a secondary cause for the osteoporosis. Or if you have a patient with multiple fractures, or they're just not improving with treatment, then you want to go back and look at this list and just go one by one and make sure that you're not missing something, right? Because if they have an underlying condition and you're just giving them a bisphosphonate for treatment, that's just a band-aid, right? You're never going to win because you haven't addressed the underlying condition, okay? So just keep that in mind. Someone who's young, someone with multiple fractures, someone who's not responding to treatment, you want to rule out secondary causes. What are the risk factors for osteoporosis? I think the most important one, and no one's going to argue with that, is age, right? And I'll show you a slide now from a recent study. As age increases, so does the risk of fracture. History of fracture is a risk factor. Don't forget the steroids, okay? A lot of patients with arthritic conditions are on long-term prednisone use. They're at high risk for developing osteoporosis. Don't forget the hyperthyroidism. Type 2 diabetes, even type 1 diabetes, is associated with a higher risk of osteoporosis. And we'll talk about that in a little bit. And then any patient with any chronic disease, liver, heart, or renal impairment are at higher risk for osteoporosis. So how do we stratify patients? Well, you look at their age, you look at their DEXA scan, you look at their FRAX score, you ask them always about a history of fracture. That's always going to be a game changer. Okay, once you have a fracture, you're at much higher risk for having another one in the future. Okay. This was that slide I was talking to you about, age and risk of fractures. So on the left, you have the age-specific incidence of fractures, and on the right, bottom right, you have age, right? And as you see, as we age, our risk of fractures increases, both vertebral, hip, and wrist fractures as well. So age is clearly a risk factor for osteoporosis. How do we assess patients for osteoporosis? We mentioned that from the beginning, right? You want to get a bone density, right? And you want to get a bone density of the lumbar spine, the hip, or the distal forearm. Always be careful with the lumbar spine. If a patient has a history of osteoarthritis of the spine, you can get a falsely elevated T-score. So just make sure in that case, you want to check the hip or the forearm. What if they have hip implants? Well, you can get a lumbar spine and a forearm. So these are the three major sites that we can use to predict fractures, okay? There is a new modality looking at trabecular bone score. I don't use it much yet because it's hard to order, but it's another way to assess whether you have a low risk, medium risk, or normal risk for fractures. So who do we need to treat? Okay, that's always the question I get from the referrals I get from the community. Who do we treat? Well, if you've had a fracture and you have a T-score between -1 and -2.5, you have to treat that patient. Remember that this number also includes the distal radius, okay? If you have a T-score of -2.5 at any of these locations, spine, femoral neck, total hip, or the distal radius, you have to treat, okay? And then, and this is what I want to spend a little bit of time on, what about those patients with osteopenia? Well, you can calculate a FRAX score, and if their 10-year risk of major fracture is greater than 20%, or if their 10-year risk of a hip fracture is greater than 3%, then treatment is recommended. Now, this says in the US, and I'll show you why that's important, because the FRAX calculator is country-based, right? So you have to pick a country or your country. I don't think Guatemala's on the list, but if you go and you look, you'll see that a lot of countries are there, and you have to pick your country first and then calculate the FRAX score. So this is what the FRAX score looks like. If you Google online, just put FRAX, this is what comes up. This is from the University of Sheffield. And what you do is very simple. You enter the patient's age, their weight, whether they're male or female, whether they've had history of fractures, whether they have a family history of fracture, whether they're using, well, if they're smoking tobacco products, if they're on steroids, if they have any secondary causes, right? Let's say they have hyperparathyroidism, then you would enter yes on number 10. whether or not they drink alcohol, and then you enter the bone density of the femoral neck. And what you do is you calculate the risk using this data. And remember, if it's greater than 20% for 10-year fracture, major fracture, you should treat. And if it's greater than 3% for hip fracture, you should treat. Now, remember, these are patients with osteopenia, right? That you don't know whether you're going to treat them or not. That's when you do a frac score. If the patient has osteoporosis, there's no need to calculate a frac score. You're going to treat the patient. You would use the frac score in those patients where you have a doubt. Should I treat? Should I not treat? That's when you calculate a frac score. On the top right is where you would change the country, in this case, the United States. So that's why the US flag is there. So the frac score is great, but it does underestimate risk in some patients. So if you remember and you go back, it says glucocorticoids here, but that's for patients taking 5 milligrams of prednisone. What if your patient's taking 7.5 or 10 or even 20? It does not calculate the risk well. So in that case, what they recommend is whatever number you get from the frac score, you multiply it by 1.15 for the 10-year risk of major fractures, or you multiply the frac score to adjust it by 1.2 for the hip fracture. So that's how we adjust for the glucocorticoids. Remember, aromatase inhibitors, they're very popular right now because they're very effective in the treatment of hormone receptor positive breast cancer. Okay. Those patients usually get about 5 years of aromatase inhibitor therapy. That drug will cause bone loss, especially in the first year. So if you have a patient with osteopenia and you don't know whether or not to treat them, what you do is you click yes on the rheumatoid arthritis button, and that'll compensate or include the risk of the aromatase inhibitor in terms of fractures. Okay. And then finally, if the patient has type 1 or type 2 diabetes, you see here it does not have it. So you would also check yes on the rheumatoid arthritis box. Okay. And by doing that, you will adjust the frac score to include their risk if they are on a aromatase inhibitor or if they have diabetes. Okay. But remember, the frac score, you only use that if the patient has osteopenia and you're not sure whether or not you should treat the patient. What is the management for osteoporosis? So we went over how you diagnose, we went over how you assess risk. What do you do with the patient, right? Once you decide I'm going to treat this patient, what should I do? First and foremost, smoking cessation. If they're smoking, they have to stop. They have to cut down on the alcohol consumption. You want them to be physically active, okay? And that's just number one. Even like for diabetes, before you even start medications, the first thing you do is you talk about lifestyle, okay? We know that lifestyle alone is not enough, okay? I don't know if you remember back when we talked about diabetes. The initial recommendation about 15 years ago for the treatment of diabetes was lifestyle modification first, wait 3 months, and then treat. If you go to the guidelines for diabetes now, you see that that's no longer the recommendation. You treat from day one, okay? Because lifestyle alone is not enough in most cases to manage diabetes. Same thing with osteoporosis. Lifestyle alone cannot be the sole treatment. You have to give them something to reduce their risk of fractures. Vitamin D is important. It's not typically found in our diet, so I always recommend that patients take at least 2,000 international units a day. The actual recommendation is 1,000 to 4,000 units, but 2,000 is just, to me, the perfect number. When you check a vitamin D level, it has to be greater than 30. Now, how high is too high? I don't think anyone knows, but anything above 30 is sufficient. Okay. Remember, when you measure vitamin D, you don't want to measure 125 vitamin D. What you want to measure is just the 25 hydroxy vitamin D, and you want to see that vitamin D greater than 30. When we talk about calcium supplementation, the recommendation is clear. You want to give more than 1,200 milligrams of calcium per day. If the patient has a good diet, then what you can do is just make sure they take maybe 1 tablet a day. They don't have to take 2 tablets a day. But if the patient tells you, listen, I don't eat much in terms of diet, then you want to make sure they get the 1,200 milligrams per day. okay? And these are the two big recommendations when a patient asks me, what vitamins should I take? Calcium and vitamin D. In terms of exercise, weight-bearing exercise is what's most important. Have patients walk, use gravity as your weight and walk for 30 or 40 minutes, 3 or 4 times per week. There's also data looking at strength training, especially in younger postmenopausal women. So that's all beneficial as well. Just be careful with the elderly. I told my dad to walk and he fell, so there you go. So just be careful. If they have an unsteady gait, maybe exercise not the best option, but they can sit down and maybe lift a few weights every once in a while. So once again, back to the same old question. Who needs treatment? And we went over this, right? Either they have a T-score less than negative 2.5, they have a history of a fracture, or you've adjusted it with the FRAX score, you treat. So we identified who we're going to treat. Now, how are we going to treat them? Back in 1984, we didn't have much, right? We had hormone replacement therapy. That's what we did, right? Patient was postmenopausal, they had osteoporosis, you would give them calcium, vitamin D, and hormone replacement. Things changed in 1995 with the introduction of alendronate. All right, that's our first bisphosphonate. In 2002, we had another shift when we had our first anabolic agent. This is teriparatide. That's your Forteo. In 2010, we had the introduction of Prolia, denosumab. That's our most potent anti-resorptive agent. In 2017, we had our second anabolic agent. That's your apaloparide. That is your Tilmus. And then finally, in 2019, the new kid on the block, that's your romosozumab. I'm not very good with these names, but that's called Evenity. And the beauty of Evenity, which was introduced in 2019, is that it's an anti-resorptive and at the same time an anabolic drug. So it attacks osteoporosis from both angles. This is a very busy chart, but this is just to show you how effective anti-resorptive therapy is. So those are highlighted in red. So you have your oral bisphosphonates, your alendronate, risedronate, and bandronate, and you see a clear 40 to 53% reduction in vertebral fractures. What's interesting, if you look at the right side where it says relative risk reduction of non-spine fractures, that's basically hip fractures. And it's interesting because it says 0 to 20%. Now, where did that 0 come from? Remember that ebandronate was not shown to reduce hip fractures. It's very good with the vertebra, with the spine, but it was not shown to reduce the risk of hip fractures. That's why you see a 0 to 20% when you look at the oral bisphosphonates. IV zoledronic acid, that's your IV reclass. That's your once yearly infusion. That one's highly effective, 70% reduction in vertebral fracture risk, 25% reduction in hip. And then finally, you have your denosumab, which is your Prolia. Very similar numbers, 68% versus 20% in the hip. So those are your anti-resorptive agents. I don't use much hormone replacement therapy. Remember that the data from the Women's Health Initiative showed that after the first 5 years of menopause, there is a higher risk of breast cancer. So I do not use hormone replacement therapy after 5 years from menopause. And the SERMs, the raloxifene, I really haven't used that in a long time. That's the one that's called a Vista. Um, at the time that it came out, we didn't have the other agents, so we did use it a lot. But for right now, I focus on anti-resorptive therapy with bisphosphonates and then anabolic therapy, with either teriparatide or the Tilmus, as you see on the screen, which are very effective as well. And then the romosozumab, which is your Evenity on the bottom. That to me is the greatest of all the agents. The problem with it, as we'll see, is it does have some possible side effects. So how do these drugs work? How do they work? So this is a nice image looking at how the osteoclast precursor cells become pre-osteoclast, and then they become multinucleated osteoclast, and then they attach to the bone, mature, undergo differentiation, and then they start resorbing bone. So remember, the osteoclast is what's eating the bone away, okay? So that the osteoclast becomes mature, right? You need the osteoblast to activate them via rank ligand. And that's going to be important when we talk about the mechanism of action of denosumab or Prolia. So let's first talk about the bisphosphonates. How do bisphosphonates work? Well, when you take an oral bisphosphonate, eventually it will be deposited in the bone. You see that here in yellow, okay? If you do IV, the once yearly zoledronic acid, same concept, it will get deposited in the bones. And what happens is when that multinucleated osteoclast attaches to the bone, it absorbs the bisphosphonate, and what happens? The cell dies. Okay, so you get apoptosis of the osteoclast. Hence, you're going to get less resorption, and that'll allow your osteoblasts to build bone. So you're shifting the balance, right? Remember what inhibits bone resorption? That's your estrogen, right? What stimulates bone resorption, right? What stimulates the osteoclast? That's PTH, parathyroid hormone, steroids, um, thyroid hormone, right? So how do bisphosphonates work? By reducing the maturation of the osteoclast and causing apoptosis, okay? So keep that in mind. The other anti-resorptive agent, which we use, is denosumab, and this is called a rank ligand inhibitor. Remember, I mentioned earlier that the osteoblasts produce rank ligand, which attaches to the pre-osteoclast and promotes further differentiation. If you block rank ligand, so you have a rank ligand inhibitor, what happens is you don't get maturation, you don't have osteoclast, and what happens? You don't have bone resorption. Okay, that's what makes denosumab very, very effective. Okay. In terms of anabolic, it's very simple. These drugs do nothing to the osteoclast. They just stimulate the osteoblast to make more bone, and now you're shifting more production. Resorption stays the same, but you overwhelm the osteoclast by activating the osteoblast. Okay, so that's why they're called anabolic medications. The newest kid on the block, the Evenity, the romosozumab. How it works via the osteocytes. All right, there is something called sclerostin, and what sclerostin does in the normal osteocyte is that it inhibits osteoblasts and stimulates osteoclast. What this medication does is that it blocks sclerostin. So what happens? You get the best of both worlds. You have stimulation of the osteoblasts and you have inhibition of the osteoclast. So that's why I believe this drug will be the future. The problem with it is that it is quite expensive. It's a once monthly injection. You see that there's 2 syringes there. Well, that's the entire dose. So they split it into 2 syringes. So you give both syringes at the same time subcutaneously once a month for 12 months. And then you transition over to either IV reclass or in this case, to denosumab. When we talk about Evenity or romosozumab, the issue with this is that in one of the trials, they found an increased risk of cardiac events in women. Okay, so that's not good. Remember, who are we giving this medication to? Usually postmenopausal older women. So that was concerning that the medication was found to increase the risk of cardiovascular events. However, further data has shown that that risk is really not there. Okay, this is what happens sometimes when you do these kind of trials. You know, it just had bad luck that that group had a higher risk for cardiac events. So right now, I don't think about that. However, if the patient has had a recent heart attack or stroke, this is not the drug for them. Okay. Remember, it's only for 1 year. You don't use it in combination with any other anabolic agent. After that 1 year, you follow it up with either denosumab or a bisphosphonate. This is once again, I mentioned briefly about the efficacy of bisphosphonates. Remember, ibandronate, it doesn't prevent hip fractures. All right. So that's why if I'm going to use an oral agent, I always use alendronate. If they don't tolerate alendronate, well, you can try the once monthly residronate, but at that point, you may be better off just switching them to IV zoledronic acid. And once it's in, and there's no GI side effects. What are the contraindications for oral bisphosphonates? Well, this drug can hurt the stomach. There's no doubt about that. So if you have a patient with a history of Barrett's disease, uncontrolled GERD, gastric ulcers, they can't stay upright. Remember, you can't lie down when you take a bisphosphonate because the pill can migrate up and can burn the esophagus. So that's why you tell them to stay upright for 30 minutes. You can go walking, you can do whatever you want, but for 30 minutes after taking it, you can't lie down. And then if the patient has chronic kidney disease, in this case, creatinine clearance less than 35 for abandronate and alendronate, I just wouldn't use it. In that case, you would use the denosumab, which does not affect the kidney. This is just a quick summary of the data presented when zoledronic acid was approved. Okay, and what you see is a significant reduction in fractures, especially in the vertebral spine. Okay, IV zoledronic acid is very well tolerated. Okay, we give it here once a year. There's only a couple things you have to do before you give this. The most important thing is you have to make sure that their calcium and their vitamin D is normal. If they have low vitamin D or low calcium and you give them IV zoledronic acid, you put them at risk for further hypocalcemia, and that hypocalcemia is quite prolonged. Okay? Remember, it's a 70% reduction in vertebral fractures. There is no doubt that this medication works. Potential side effects, you feel like you have an illness sometimes, like after you get the flu shot, that you don't feel good for a few days. To prevent this, I have them take Tylenol 500 with each meal the day before and the day after the infusion. That tends to work just fine. Remember, just like the oral bisphosphonates, you cannot use this drug if their creatinine clearance is less than 35. And we mentioned that here. Okay, be careful with hypocalcemia. Check the creatinine clearance and make sure that their vitamin D is. Now, I mentioned the oral bisphosphonates. If the patient takes an oral bisphosphonate and they have severe body pain, they're going to have severe body pain with the IV formulation. So in that case, you're going to want to use another agent. But if their only concern is GI upset, that's the patient you want to switch over to IV Reclast. In terms of drug holidays, the recommendation is that after 5 years of oral bisphosphonate treatment or 3 years of IV zoledronic acid, you can take a holiday. But remember, you're only going to take the holiday if their bone density is better, right? If they haven't suffered a fracture and if they don't have osteopenia anymore, right? Osteoporosis anymore. Why do you want to take a holiday? Is that prolonged bisphosphonate use does increase the risk of femoral neck fractures, okay? And we're going to talk about that in just a second. Atypical femur fractures is more correct. When you do a drug holiday, you can take a holiday for about 2, maybe 3 years. The IV formulation lasts very long in the bones. So that's why you can stop the medication and just follow the patients, have them continue to take calcium, have them continue to take vitamin D, and then follow them over time. If they develop a fracture, unfortunately, or if their bone density declines in the future, then you restart the medication. But remember, a drug holiday from bisphosphonate is to reduce the risk of atypical femur fractures. Now, what is an atypical femur fracture? It's a fracture of the femoral shaft below the neck. All right, so it's in this area right here. If you get a fracture right here, most likely it's because you were on long-term bisphosphonate use. Okay, fractures of this area of the femur require a very high impact. Okay, usually it's a motor vehicle accident or a fall from a very, very tall building. You'll fracture the femur like this. When you see a fracture like this in a patient with osteoporosis, the most common cause is going to be long-term bisphosphonate use. Okay. We mentioned briefly when to restart. Well, if their bone density declines or develop a fracture, you want to restart. Remember that zoledronic acid has the highest affinity of all the bisphosphonates. So you can actually, with the bisphosphonate, the IV, I give it for 3 years, and usually they're off the drug for about 2 to 3 years. And then we decide whether we're going to restart or we're good to go. When to switch bisphosphonate therapy, we get this consult a lot, right? Patient is on an oral bisphosphonate and their bone density continues to decline, then you want to go ahead and switch them to either denosumab or maybe even an anabolic agent. You always want to make sure that they're taking the medication. Let's say you have a patient on alendronate, and now they're going to start on aromatase inhibitor or steroids. In those patients, I would switch and give them something a little stronger like denosumab or anabolic therapy. I mentioned briefly denosumab. It's an injection, subcutaneous injection every 6 months. Okay. This is my go-to next step after bisphosphonate therapy. It is indicated for both men and women, and it's also indicated for those patients on aromatase inhibitors. Remember, when you're on aromatase inhibitor, the first year is when you're going to lose the most in terms of bone. You got to treat these patients right away because they will develop osteoporosis. Remember that denosumab is not cleared by the kidney, therefore it is safe in patients with low creatinine clearance or low GFR, including dialysis. Potential side effects, just like the bisphosphonates, you want to make sure that their calcium and vitamin D is normal before you start. They can get a skin rash, very rare. I've not seen many. Osteonecrosis of the jaw is a possibility, but remember it's 1 in every 100,000 patients, so it's not that common. But just make sure they see their dentist regularly. If they're going to have an oral procedure, oral surgery, they're going to take out a molar or they're going to put in an implant, then you're going to want to hold off on the Prolia. But if it's a root canal, cavities, deep cleaning, anything like that, you can continue the medication. The thing with Prolia, there's always a catch, is that you can't just stop the Prolia, right? Give 2 doses and stop, because this was a very important study published by Cummings in 2018, where he found that if you stop the Prolia or the denosumab and you don't replace it with something else, that these patients actually had a very high risk of vertebral fracture within the first 3 months of discontinuation. Okay, so remember, if they're on Prolia, you have to tell the patient, if you're going to stop using it, then we're just going to have to give you something else. You can never stop the Prolia and not replace it. So typically, I replace it with IV Reclast or PO alendronate, but you can never just stop the Prolia because of the increased risk of vertebral fractures. As I mentioned earlier, every time I see a patient who's on Prolia, I tell them we're going to use it for about 10 years. The data so far shows that it's safe for up to 12 years. After 12 years, we just don't know. Okay. For the most part, once they're getting close to 10 years, I'm already thinking about switching them to something else. And then maybe taking a drug holiday. But you never take a drug holiday from denosumab. You only take drug holidays from the bisphosphonates. Why? Because remember, bisphosphonates, they get deposited in the bone, and that's why they last for so long. The Prolia, within a month, the medication is gone, and you have a very high risk for rebound fractures. So these were the take-home points for the Prolia. Remember, the safety, we know it says 10 years now, but we know now it's safe for up to 12 years. And remember, you have to transition to another medication. You can never stop the medication abruptly. When we look at the anabolics, remember the anabolics are used for 18 to 24 months, and then you switch over to an anti-resorptive agent. These drugs are highly effective. If you look at the apaloparide, that's your Tilmus, you see 86% reduction. Remember that for zoledronic acid, it was a 70% reduction in vertebral fractures. Here you see 86. So what you want to do with these agents is build bone, right? You build the bone and then you maintain the bone with either a bisphosphonate or denosumab. And then on the bottom is your Evenity. This was compared to alendronate, but Evenity is very good as well. Remember, that's just for 12 months, and then you transition to something else. Once again, the anabolics, there are some contraindications, okay? There is a risk for osteosarcoma, right? So this is not for everyone, right? If the patient has a history of bone radiation, personal history of osteosarcoma, or family history of osteosarcoma, or even Paget's disease, those are not good candidates for this drug. The duration of treatment is 18 to 24 months. Okay, these are injections that the patient gives at home daily. They come in pen devices, just like if it was insulin, very easy to use. And remember, these are anabolic agents. You're going to build bone, and then you're going to save the bone by switching them over to a bisphosphonate or to denosumab. Okay. And then finally, this is the data on the romosozumab. This is the Evenity. And I just wanted to show you this because it is a game changer. I mean, this is going to be the future. You give them this medication for 1 year. So what you're looking on the left is alendronate versus Evenity, and you see a significant reduction in vertebral fractures. And then after 1 year, you're going to switch everyone to alendronate, and you see that the difference persists. So you see a significant reduction in vertebral fractures with a significant increase in bone density. Who are the candidates for this medication? Well, these are my most severe osteoporotic patients, no doubt. Patients who have bone densities less than 3, you should always consider anabolic agent. If they have multiple vertebral fractures, I think they're a great candidate. If they have a family history, right, of osteosarcoma or Paget's, and you can't use the other 2 anabolics, you can use this medication. But remember, there is an increased risk of cardiovascular events. Therefore, if they've had any event within the last year, then they're simply not a candidate. It has not been approved yet in men, although those studies are ongoing. And you can use it in patients with renal impairment. So remember, for the kidneys, the only ones you can't really use when you have low GFR or low creatinine clearance would be your bisphosphonates. Again, caution with those patients with history of myocardial infarctions or stroke. Okay. So what is this is the last couple of slides. How do I treat patients? How do we treat patients? What do the guidelines say? Well, we follow something called sequential therapy, right? So everybody honestly should start on a bisphosphonate, okay? Unless they have severe osteoporosis from day 1, right? They have a T-score less than -3, then you may consider starting them on denosumab first, okay? If they have severe osteoporosis and they've already had a fracture, then maybe you want to do one of the anabolics or the Evenity, okay? But bread and butter, right? What do these patients need? They need an oral bisphosphonate, okay? If they don't tolerate it, switch it to IV. If they have severe osteoporosis, then you may want to think about using denosumab first, okay? But for me, almost all of my patients, the first drug I give them is alendronate, right? It's generic, it's cheap, and it's effective. So in summary, we talked about how to diagnose osteoporosis, but I think the most important thing, we talked about how to treat it, but fractures is the name of the game. We need to prevent fractures, okay? Calcium, vitamin D, medications, lifestyle modifications. We got to do all those things because a fracture changes everything. I think there was a study looking at men who fracture have a 50% mortality within the next 12 months, right? So we have to prevent that first fracture. In addition, fractures cause chronic pain, right? How many of us do we have patients who have had a vertebral fracture, a T12 fracture? That pain's forever. That pain never goes away. So if we can prevent that fracture, we're preventing years of pain and morbidity for our patients, okay? Remember also, you got to treat. Don't just do lifestyle changes. You got to give them something, and alendronate is a great choice to start. But once things get complicated, if they progress, then remember you have other options. Denosumab is my second choice. Then you have your anabolics, and hopefully in the future we'll have more access to Evenity, because Evenity, remember, attacks both. It's an anti-resorptive and an anabolic medication together. So this is the final slide. Remember, the first thing you want to do is identify the patient, identify their risk. But like I mentioned, to me, the drug of choice is an oral bisphosphonate. Then you monitor if their risk increases. If they start a medication that we know can hurt their bones, they're on an aromatase inhibitor or on steroids, then you want to augment therapy, maybe to denosumab or an anabolic. And then finally, those patients with severe osteoporosis, those are the only ones that I would probably start with denosumab first and then reassess. Okay. So that is how we view osteoporosis here at Baptist. We follow the guidelines. Okay. We went over the guidelines on how to diagnose. We discussed treatment options. But remember, at the end of the day, our job is to prevent fractures. Okay. That's what we have to do. That's why it's so important to screen your patients. That's why it's important to identify secondary causes and treat those causes. because if we can prevent that first fracture, then we've saved the patient years of pain and years of possible comorbidities. So I want to thank you for your time. It's been a pleasure to be able to share these slides with you, and I look forward to the opportunity to someday meeting you guys in person. And once again, thank you for your attention.